Another exciting episode. Welcome to the Ahaki podcast. I'm Solomon Senwanja. On this particular series, we focus on litigating reproductive health and rights in Africa. We're getting experiences from lawyers, judges, medical workers, and the people in charge of these services. On this episode, I'm really excited to be hosting Dr. Peter Igogo. Dr. Peter Igogo is a gynecologist, obstetrician, and a medical expert with the Medical Support Network Kenya joining us today. Daktari, karibu sana. Welcome to the Ahaki podcast.
Thank you, and I'm happy to have this opportunity to discuss this important topic with you.
I'm so happy because I've been hearing from the lawyers, from the judges, from the people. Now I have a medical practitioner. The intersection of the law and medicine is one to be discussed, especially in access to healthcare for the people of Kenya. What has been your experience like with dealing with people who want to access services? What's that intersection of the law and sexual reproductive health and rights services for your people?
Thank you very much. And I'll talk from my experience in my practice in Kenya, where I've practiced for the last 20 years in sexual reproductive health.
Wow.
And before 2020, we did not have provisions of providing sexual reproductive health services, especially safe abortion services. What we had was what we call the penal code, which was inherited from the colonial times. And this penal code was penalizing both the doctor, the woman coming to seek services, safe abortion services, and the person providing equipment or drugs to procure that procedure. And that was restricting providers from providing this life-saving service. 2010, we had the new constitution, which provide avenue for providing safe abortion services under 4 circumstances. You can provide safe abortion services in case of an emergency. A girl or a woman come with an emergency related to that pregnancy, you can safely provide safe abortion services. If the life of that mother is in danger, or the health of that mother is in danger, or in any other written law. Any other written law, like the Sexual Offences Act, provide that if a person is raped or a child is defiled and get pregnant and does not want to keep that pregnancy, you can apply that act to terminate that pregnancy. So that has been the enabling environment for us to provide services. But the penal code I talked about earlier is still in place. So that limits us because we've had cases where providers have been taken to court based on the penal code, that you're providing services against the penal code. So that has been the limitations. We have the provision in the Constitution, but we have the penal code which tie our hands in providing these safe services.
So then you're stuck in the middle?
Yes.
Have you had to chase away some people?
Unfortunately,
and what has been the impact? Yeah,
we had an opportunity a few years back. We developed standards and guidelines for health providers so that they can provide these services. Unfortunately, the then Director of Medical Services withdrew those guidelines. And we used to use those guidelines to train doctors, nurses, and clinical officers to provide services, even in public facilities. But the moment they were withdrawn, it meant that you cannot provide those services, you cannot train the providers for that. So yes, we've had cases where girls and women who need that service have come seeking services, but we are forced to chase them because we don't have guidelines or the providers have not been trained. Mm-hmm. Unfortunately, whom do we chase away? These are girls and women who cannot afford. And that's the discriminatory part we are talking about. Because a person who can afford a service can go to a private hospital, pay for it, even get admitted, have an insurance cover, have the procedure done safely. But that person who comes from low socioeconomic status, Mathare, Kibera, Kawangware, who has no much income is the one who's chased away. And unfortunately, when you chase them away, where do they go? A woman, once she decides to have an abortion, will do anything to have that pregnancy terminated. So they go to Backstreet and they come to us. I train medical students. We work in a public facility, and we get these girls who go to Backstreet abortions and then come to us with very severe complications.
For post-abortion care.
Post-abortion care, which is very unfortunate because some of us end up dying. Some of them end up dying or with other life-threatening complications.
Yeah, and even the strain on the national budget of Kenya for post-abortion
care. Yeah, the
care.
resources. Actually, thank you for bringing that up because in public facilities, public hospitals, if you go to the gynecological wards, 80% of the patients who are admitted there are having abortion-related complications. So it's a strain on the health provider, it's a strain on the resources and the government budget as such. And I believe it's the same in Kenya, it's the same in Uganda, it's the same in most African countries.
And yet the laws sometimes are not, I mean, in Kenya at least, somehow there is that, you know, the most recent law,
yes.
But the penal code still exists.
The penal code is still, yes.
Do you think that the legislators are listening to the data and statistics from you, have, you know, and the evidence that you present as medical workers to the reality of this issue of access, for example, to safe clinical abortion?
A lot of research has been done. The recent one showed, like in Kenya, every year we are losing 26,000 women and girls from unsafe abortion.
26,000?
26,000. It's a huge number. And about 151,000 every year are admitted in hospitals with abortion-related complications. We present these numbers to the registrators, but unfortunately, they don't put faces to these numbers. We put the numbers across, and even those case studies, but unfortunately, because we had a case in Malindi back then, and the court was very clear that the parliament needed to actualize the Article 26(4) of the Kenyan Constitution, so that the Constitution is a framework, but we need to put meat into it and you actualize it so that it's clear and what conditions can abortion be safely be provided. Mm-hmm. But unfortunately, our parliament has not done that, which is very, very unfortunate. So we still continue losing mothers and young girls from abortion-related complications.
Dr. What would you want the legislators and the people in charge of the law to do to save the lives that you're saying are being lost?
I want them to listen to the doctors and providers because we have the first-hand experience. 2 days ago, before I came to Uganda, I was called in theater for this girl who had procured an unsafe abortion. She had injured her uterus. She had injured her bladder, that is the urine pocket. She had injured her gut. We removed the uterus. We put the tubes everywhere. And when I left her, we had admitted her to ICU. We've had those cases every other day. We end up losing those young girls. She was 16 years old. Very unfortunate. So my point is, I wish the registrators could visit some of these hospitals and listen to those cases that we go through and the women go through so that they can do what they're supposed to do and actualize, because we have the Constitution, but it has not been actualized. We have the documents. We have the very, very good documents. I mentioned about standard guidelines, which are very clear on what should be done, including the training. We have other guidelines, like the guidelines on prevention of maternal mortality from the Big Five, abortion being one of them. But unfortunately, just about when we are about to launch and disseminate those documents, there's a letter from the Cabinet Secretary of Health, don't launch these documents. So our hands are tied. So I wish the registrators could come in and actualize these provisions and enable us to train providers, including medical students, so that they are able to provide these services safely. The drugs to procure abortion are registered in Kenya. There are 2 drugs. One is called misoprostol. The other one is called mifepristone. Those drugs, even the women and girls can take at home, what we call safe care. But unfortunately, the providers' hands are tied because police continue arresting providers, arresting these young girls, putting them in cells, taking them to courts, and putting charges against them. And actually what this does is that it scares the providers and girls from seeking safe services. So my plea is that these registrators can enact laws, and not enact, but actualize what is already there, because you have the progressive constitution of the 2010, so that the women and girls can benefit from these provisions of Article 26(4) of our constitution.
Is there a need also for massive sensitization among the health workers?
Thank you very much. Yes. It's unfortunate because I'm a lecturer in a medical school, local medical school. A few years ago, we used to have a curriculum of training young medical students about sexual reproductive health services, including abortion. But unfortunately, because of anti-rights movement, this part of the curriculum has been withdrawn. So we need to sensitize the medical students, the nursing students, the young doctors, obstetricians, and gynecologists, so that they know the provision of our constitution. And we are working closely with lawyers in Kenya through what we call Legal Support Network. And it will be very important if we can bring them on board so that they can sensitize the health providers on the provisions of the 26(4), which allows safe abortion services under the circumstances that I mentioned earlier.
Great. Any success stories to share about this collaboration with the legal fraternity in Kenya?
Yes. We have been doing what we call compliance visits. We collaborate with the lawyers, Legal Support Network, and visit the clinics so that the providers, we empower them on provision of safe services. We make sure they have the right equipment, their licenses are in order, and this actually prevents them from being arrested by police. That is one of the success stories. The other success stories is the case we had in Malindi, Kenya. This was a young girl of 16-year-old who had a spontaneous miscarriage. It came out on its own. And then she went to a health provider nearby. And then postnatal care is allowed in any hospital, including mission hospitals. So a procedure was done to complete the procedure, which is legal. But unfortunately, 2 days later, the police raided the clinic, arrested the provider, looked for the girl, arrested her, and took the medical records and the equipment. And the case went through the full trial. The provider was accused of procuring an abortion. The young girl was accused of going for termination of pregnancy abortion. I was called in as a witness by the lawyer, the Legal Support Network. And what I told the court is that because this girl, when she was taken to cell, she was forced to go to a public hospital for a medical examination against her will. And that was very against her dignity, even body autonomy, that she was examined against her will in a public facility. So I told the court that the raiding of the medical facility was illegal. It taking away the records. We have a Data Protection Act in Kenya that was against that act. The equipment that was taken can be used for any other gynecological case, can be used for any other procedure. So you cannot say that because you found this equipment, this is evidence that the person provided abortion services. So I gave that evidence, and we collaborated very well with the Legal Support Network, and that case was dismissed, and actually the parliament was instructed to make sure that Article 26(4) of our constitution is actualized so that we avoid such cases like the Malindi case I'm talking about. The second case was a girl in Kisii in the southern part of our country. A young girl went to a facility, could not have a safe procedure because the guidelines had been withdrawn. So the providers could not help her. She went to another facility, the same thing. She went for backstreet, had a complications, was admitted in ICU, died 1 week after. So, with the support of the legal support network and the medical expert, we sued the government and the county hospital that the withdrawal of the guidelines are the ones which contributed to the death of this young girl. And we won the case, and the Minister of Health was instructed to reinstate the guidelines. But unfortunately, an appeal has been put across against
by
that ruling by the Attorney General. We are still in the appeal case. So, but those are some of the positive aspects that I can talk about our collaborations with the legal support network and the medical experts.
Very, very interesting.
Yeah.
What does the future look like?
The future looks bright in a way, but it's 50-50.
Tell me.
Bright in a way that we are hoping after the appeal, even before the appeal goes through, we can have the stay of those guidelines being reinstated. They are very comprehensive. They will enable us to train doctors, to train mid-level providers in providing services, including public services. We have the drugs which are registered. And those drugs can even be taken at the comfort of the girls or the women's homes. They don't have to come to the hospital. We give them instructions, and they take the medicine at home. That's a bright part, and the constitution as well. The green part, the part that is not very clear, is a part that we still have opposition, which is very strong. I talked about the indoctrination of the medical students in their first year, where they are taught about family values, our culture and traditions, and then they are told abortion is against our culture and values. So the strong opposition, it's something that is working against the provision of these services. Unfortunately, as I said before, who suffers is that disadvantaged girl and woman who gets to backstreet abortions and suffer complications.
I hear you. Dr. Peter Igogo, thank you very much for speaking with us and sharing your experience on this subject. Thank you very much.
Most welcome.
Great.
And thank you for having me.
Always, of course, come back. I've been speaking with Dr. Peter Igogo, an obstetrician and gynecologist. He works with the Medical Support Network of Kenya, speaking to us on that subject. Thank you so much for being part of the Haki podcast. I'm Solomon Serwanja. Catch you next time.